Okay. Very good. Tell me when you're ready.
Yes, ready.
Okay, so what do you think of this MR? What can you tell me about this MR imaging?
So there is arterial signal.
Come a little closer.
Sure. So there is looks like arterial signal in the right transverse and sigmoid sinuses.
Region, yes. But it doesn't look like a sinus, does it? In other words, it's not one tube,
That's right.
right? This is one tube. So you see,
Multiple
right?
small
Multiple.
channels. Yeah.
So you already know that this they do looks vascular, right?
Yeah.
It's not like an infiltrating tumor, right?
Yeah.
And then we have prominence, right, of the sinus. Okay. Whenever you see that, what do you think the etiology of this disease is? It's a dural fistula, right? We can see it very nicely here, right?
Yeah.
So when you're looking in a patient with a dural fistula, anywhere, you look for the arterial supply and all that. But what is the pathophysiology of the disease?
So from what I've read, the dural sinuses, they have some arteries that feed their the wall.
The wall.
And then they form the connections.
Okay, so there is the normal blood supply to the wall of the sinus. That is correct. Okay, but something else has to happen for a dural fistula to develop.
That's usually a lot of people say that's trauma.
Trauma is always, if you ask, that's why in medicine trauma is so frequently blamed. Tell me, have you ever hit your head?
Yes.
Okay, so you asked the question, but trauma, I would say, is one of the least frequent reasons for a dural malformation. Yes, you can have a meningeal fistula from post-traumatic, you can have a carotid cavernous fistula post-traumatic, but the dural AVM of the sinus is a post-thrombotic phenomenon. So there has to be thrombosis of the sinus as a precondition to the shunt to occur. Okay? So you look and you try to find if there is any evidence of thrombosis in the sinus, okay?
Yeah.
And we start seeing something that looks suspicious you don't see on the other side. You see what I'm talking about? And then you see the hyperemia, tremendous hyperemia, right?
Yeah.
Okay. Now let's go into correct to do an angiogram. Now the patient's only complaint was noise.
Yes.
Okay, no cranial nerves, nothing like that.
No.
Okay, in a posterior fossa, right? We know where it is, right? You know, no question. You knew the diagnosis before the angio.
Yeah.
Okay. So what is your protocol? How do you work it up? What is the blood supply to the region?
I mean, it's mostly from external.
From the dural surfaces.
Yes.
I wouldn't say external because that's too simplistic. It is dural supply. The dural supply comes from the external carotid is for kindergarten. You guys, you're in your PhD. So what is the blood supply to the dura?
Mostly, so meningeal, middle
Meningeal.
anterior meningeal branch of ophthalmic.
The anterior meningeal, yeah.
Then posterior
Called
meningeal.
Folsine artery, yes. What else gives blood supply to the dura?
So posterior meningeal from vertebral.
Yes.
And also some of the other EC branches that dig into the skull. Like
Wait, which one is my favorite artery? The smallest, call it the most dangerous, smallest, smartest artery of the external carotid artery, the ascending pharyngeal. The ascending pharyngeal is such a fascinating artery. The ascending pharyngeal, the occipital, have the same autoregulation as the cerebral arteries, whereas the internal maxillary itself, well, internal maxillary may, but the fascia, lingual do not have. They are like systemic blood vessels. Okay, so the middle meningeal artery, ascending pharyngeal artery, occipital artery. What meningeal branch comes from the occipital?
Posterior meningeal?
No, the so-called posterior meningeal comes from the vert, the transmastoid, and we're going to go over it in a second. Okay, so the occipital with the transmastoid. You may have things like posterior auricular and things, parasitation later on. Transbony, superficial temporal. So in your mind, you build the puzzle of this thing, right? So in this area, we can predict that the primary supply will be from the meningeal arteries that we described. Middle meningeal most likely because it's so dominant. But yeah, so we're gonna have to do that kind of angiogram. Now you did first injection is the left. This is a right side lesion. You got my first shot here is the left vert. That would have not been my choice, but it's okay, It's okay. So here we see the left vertebral. Do you see any supply to the malformation?
I do not.
No, correct. The next thing we do, there's reflux here, so so there is already a hint of something.
Yeah.
Okay, but then I go, and it's very important this injection to me to see if there is or not thrombosis. Okay, so the venous system of the posterior fossa is best well studied with the vertebral injection, right? So in the right side, look, we have a nice. This is what sinus is this?
Sigmoid.
Sigmoid sinus. And what am I missing here? Or this not opassing properly? Come on. Yeah. What am I missing here? This is a patient presented with bruise, with hearing, and that we didn't go about bruise. There are subjective and objective bruise, right?
Yes.
What's the difference?
Subjective, the patient hears. Objective, you can hear with the scope.
Right. So you can hear it. If you put a stethoscope, you can hear it. Why do they have this brewery business? Why do they have this? Do you know what the reason for them? Do you ever know about the Indians and the cowboys? How come the Indians knew that there was something coming? Right. There's no Indians in Iran, I know, but we got.
Well, they are original Indians.
Yeah, no, I'm just kidding. But what it is that bone is a solid, and solid are the best transmitter of sound.
Yeah.
Okay, so when you have the rushing of blood in the vitreous bone, that's the noise that the patient hears. Okay, now in this particular case, if you put a stethoscope, probably the sinus is not thrombosed. You will hear it
because of high velocity.
Yeah. Okay. So we went over the blood supply to the meninges. How? Okay. So I got a diagnosis. It's clear. So what's my protocol? So the first injection was the contralateral. The lesion is on the right, so the left vertebral. It's not my favorite, but it's okay. So what I'm going to use this injection for? I see no supply whatsoever to the fistula. There is reflux to the opposite side, right? So we're going to wait for that. But we're going to use it to look at the venous system. Okay, so here we have a big sigmoid, big jugular, but we're not seeing the transverse sinus. On the opposite side, what do you see?
Slimmer sigmoid.
Yeah, smaller, so looks end.
There's already some like non-opacification.
Well, it could be hypoplastic, it could be developmental in nature. Now, look at the density of contrast here, okay? And what's going on with the density of contrast here?
Dilution?
There's dilution. So I cannot say if this is thrombose. This could be just washout. And the washout can come from where?
From the other suppliers of the region, like the right vert branches, posterior meningeal.
A little higher up. We're going to see when we do the carotid injection, we're going to see how the brain drains. And it's not infrequent that one side is dominant to the other. So it could be the dural fistula, of course, could be possible. Could be thrombosis, but could be dilution. Here I'm happier because I see the density of the contrast much less diluted, and the size is kind of corresponds to what we're seeing. Plus we're seeing a very prominent cortical vein of the cerebellum coming here. Okay? So this, in my estimate, is that probably is developmental, is the way the patient was built. Okay, this is as much as we can take out from the vert injection. Now we go into the right common carotid artery. Okay, so the right common carotid artery already tells you, although this picture is no more informative than this picture. So we're gonna need to do better than this, right?
Yeah.
Okay.
If we have done better.
Now, one thing that I always fascinated, how old is 40? She's in the 40. So one thing that I'm always fascinating is patients with AVMs seldom, no matter the age, seldom have atherosclerosis. I think the increased flow somehow protects you. Okay, so the common carotid artery is not very useful. We're going to use it the same way. Okay, but you didn't carry it well to the venous face.
I think that, like, I realized this is a wrong shot. The catheter tip was supposed to be in the external, but
Okay, I like that. You see, that's very helpful. Okay, so we repeat it, and you're still not happy. Now we do a better injection here. How much did you inject?
Usually I inject about 4 or 5 cc.
Okay, don't be shy in dural fistulas to inject more contrast and longer time because you want to pacify the sinus. Okay, what do you see in this injection? There's one artery when we went over that we forgot to mention.
Yeah, so there is a artery that we don't often see traveling from midline to lateral.
Okay, this one, right?
Yes. So this is,
Can you tell me where it is in the lateral view?
so on the lateral view, I think it goes along the tentorium. So that's called tentorial.
We're going to debate about it. It's this one here, right?
Yes.
And what is this?
And this is the sigmoid sinus.
Okay, so this is supplied to the dural fistula.
Yeah.
When it comes from the cavernous segment of the carotid artery, right, there are two variants. One, when it goes medial like this, and then we call the medial tentorial. And when it goes down like this, we call it the basal tentorial artery. We went over to some other the other day. Okay? You're also making a lot of cognitive things. For example, very good PCOM, right?
Yeah.
So you have to start on thinking about those things. Now we're going to try to see the late venous. There you go. Okay? So here you see the drainage of the supratentorial circulation shows you that sinus, right?
Yeah.
And now we know that because of the common that the fistula is from here down. There is an interesting diverticulum here. This actually could be another cause of hearing a noise.
Like a dead end.
Yeah, no, and actually it could be a very disturbing noise. And a guy in France, what's his name? Udar, presented, when we started with the coil, he was coiling these things. And it goes away. The noise goes away. Okay, so if you do a fistula after you fix the fistula, doesn't go away, you bring it to treat this. Are we together?
Yeah,
Okay.
absolutely.
So we continue. I'm going to leave that there because I don't know what this one is. There are some times in dural fistulas, when you're doing the workup of dural fistulas, that if I see this, I may change, instead of good diluted 50% contrast, I would like to put pure contrast because of the dilution effect. You will get a better opacification. So here you also see another important thing of imaging. Okay, what's going on here? What's happening here?
I'm moving, like swallowing.
Swallowing, yes. The moving, because the head is not moving. Look, right?
Yeah.
The head is very nice. You see something, here, and you see the jaw move. So it's swallowing. Do you remember what it's the patients that are awake or sedated? Sometimes sedation is your worst enemy because they kind of sleep in the. So one thing that works very, very good is to train with the patient first. You tell the patient, you take your tech and say, when I put my finger down, you should, but not before. So you basically take a deep breath in, blow it all out, take a deep breath in, hold your breath, don't, because if you just hold your breath, you may get the patient in half inspiration, half expiration. But if you actually do the exercise, and then do it in and out, and then in, and then you stop it, it works. You get much better picture. So you're gonna have a little bit of a hard time with this patient. So let's see what we did next. Okay, a better center. Okay, and better instruction to the patient. Okay, very good. Okay, so let's analyze. We're going to make this. I know what we want to use those two. Okay, so we're going to put this. We're going to put this one here. And we're going to put this one. I like this picture here. Okay, so we're going to make it a little bit bigger for the. Okay, so we're going to analyze what's the blood supply here, senor. It's a nice variation actually of the meningeal artery, right? What artery supplying the lesion?
So there is.
Don't tell me external carotid. That doesn't exist.
No, of course. It's not the external carotid. It's past the.
Okay. So, how do we identify it? What is this one? And how do I know?
Ascending vertigo.
No. You know it's my favorite artery, but it's not the ascending vertigo. What is this artery? Remember we went over. This curve helps you a lot versus this curve here.
Oh, this okay. So it should be a branch of posterior stylomastoid.
Well, no. I can't tell. Let's say I can't tell. So instead of going from center to peripheral, go back. What is this?
This is a branch of this.
Remember what we went over when it goes beyond the bone?
Yeah.
It's superficial temporal. So it's a scalp blood vessel, right? So if I can't figure it this way, I figure it backwards, right? And then remember when we went that the superficial temporal, when it comes through the zygomatic bone, gives you a curve? Because it's got to come from a deep position to a superficial position. That's how you identify. Okay, now the middle meningeal artery is interesting because you got this branch to the petrosalus, which is, of course, the one supplying the fistula. But from the accessor meningeal, you have a dominance to the anterior branch. And if you remember that we used this curve and this curve, in between here is the ILT, right?
Yeah.
Between those two, we look for the anastomosis with the internal carotid. Okay, so it's a variation of the middle meningeal.
So when I saw that, what you mentioned, accessory meningeal, I thought this is middle deep temporal because I was always thinking.
Here's the inferior dental.
Yeah.
When the inferior dental, I forgot the deep course of the internal maxillary, then the mid deep temporal will have in the same trunk. When it's superficial, they will have a different branch. I think this is foramen. Here's foramen spinosum. This is definitely a meningeal branch, so I'm tracing it backwards, right? This is where the mid-deep temporal would be. Here, the dominance is the anterior deep temporal,
Yeah.
to the temporalis muscle. But this could have been, you could have, yes, I cannot tell you exactly what it is, but this definitely is middle meningeal, so I have to think a foramen ovale for this vessel to enter the base of the skull, right? Are you together? I see something here that is fishy, but we'll analyze it later. Okay, and you see here the anterior deep temporal comes towards the orbit. And let's see, yes, here it is. Right? Here it comes towards the orbit.
Mm-hmm.
So that's going to be furthest foramen will be there. Right. Nice variation of the meningeal branch. Okay. So now, remember I like my picture, this one, so where did I get this one from? The MR Angio 2. This one I got from the source images. So I'm just going to put it here for a moment because this is very important for us to rebuild that anatomy, the territory. Okay, you already see, by the way, you already see prominence of the meningeal, right? Okay. I don't know what this thing is doing. Okay, so we've done part of it, right? We've done part of it, but we need to cover all around this sinus. So go back to the angio. So what's going to be your next injection?
So we haven't, so we're missing the occipital.
The occipital. Okay, yes, any pharyngealist, you know I like her very much. She's the beautiful artery. Okay? So wait, what did you get here? So what artery?
I think this is posterior auricular.
That's posterior auricular, yes. And you see how indirectly comes to the fistula.
And that's a stylomastoid.
Sorry?
So that prominent medial branch is a stylomastoid, right?
No. This is it's a bad branch. It's in the lower part of the. It's here. It's in this part. It's a cutaneous branch. It is posterior auricular. We have. So let's see what we do next. Okay. And which one is this?
Occipital.
Correct. Okay, so the occipital, and if I put my middle meningeal here, okay, so I'm starting, here is the superior part, right?
Mm-hmm.
Anterior superior part of the supply to the dural fistula, and here you have this network, which is in another part of the wall of the sinus, right? So we're starting to reconstruct what we saw in the MR. Still missing something. Okay, I'm going to use this for a moment. This is the same one, you went back to it. Okay, so you went back to this one, you just need to do it a little bit lower. And here is the vertebra. I'll put it there for you, just want to see what I'm seeing. Okay, here the patient is tired and moving and so on. Okay, so we're missing something. Missing something here. So this is a hypoplastic segment, and the other side was dominant. Okay. So there is something missing. We're going to look at the. Okay, so I'm going to go back to your common carotid injection and see if I can figure out.
I think we also did a 3D reconstruction from right common.
No, but you know, here is that posterior auricular branch. Here is the occipital branch. I'm looking for the ascending pharyngeal artery. Okay, and okay, no, this is not it. This is just a flow. It's a flow problem, right? Just the way the contrast is coming. It's not unreasonable when you have this problem to do a better injection here with more contrast to fill up the stuff better. And let's continue with the left. Okay, so this, yeah, this is what I have here. Okay, so I don't see any obvious supply. This is the left common carotid artery. Okay. Okay, and what else you did? Here is the, very good. Okay, so you did this. Here's the occipital. Look how nice. This is, remember we talked about the transmastoid branch? This is a variation of that. How do I know that this is supplying an intraosseous blood vessel? Remember our principles of...
Not very tortuous.
Oh, this is an unbelievable variant. Because I trace it back. I find this is, I'm sure that this is a meningeal artery. So I trace it back, right? It had to go into a foramen. Foramen spinosum gives you a sharp curve. Foramen ovale gives you a sharp curve. I don't know this is the name of this, but this is a cutaneous branch that gives a bony artery here. You see it here. Goes in through some type of bony foramen in to the, and then this is what we were missing to reconstruct that dural fistula. This will supply the dural fistula. Interesting, eh? This is quite a variant. Here you see the cutaneous branches, right? Same principle. Goes beyond the bone.
Yeah.
It becomes intertable, okay?
It's a dural.
It's right. It's dural and reaches the midline. Okay, so here, interesting variant. But there was the piece of the puzzle. We'll get back to the dural fistula itself in a second. We're just finishing the cartography. Look at that. Look at this middle meningeal behavior. Okay, look how fabulous. Okay, you see this? What is this?
From spinous.
So that's middle. I'm identifying my arteries. That's my middle meningeal artery. This artery, look at that, very dominant. And here is the petrosal branch. So one of these two may supply the seventh nerve. Okay?
Yeah.
But what about the orbit? What about the orbit?
So this looks like a lacrimal.
Yes. Yes.
Meningeal lacrimal.
Yes, same thing. There must be a hurdle foramen right there. Must be some on the other side. Okay, you see it here.
But there's no contribution.
There's no contribution
to retina.
Okay, so now we got to go back to dural AVMs.
Is it autosyngiosis?
It's what?
No, I was wondering.
Ask me the question. I didn't hear it.
So the posterior branch of MMA kind of goes and ends in a arterial blush, in a capillary blush.
Yeah.
I was wondering if that is some PL contribution leading to that capillary blush.
No. Well, then let me put this one back here. What are you trying to say? Here?
Yeah.
No, there's no PL. That's very rare that you get. I don't see no cerebral arteries here.
Okay.
That's just the meninges. It's the membrane.
Okay.
You guys got to learn, and I've got to see middle meningeal artery a lot. You know, you're doing a lot of meningeal, right? How many dural hematomas, embos?
Yeah, we usually do them in one session. We evacuate and then embolize MMA.
The new paradigm as of Tuesday. No, but we do a lot of.
You evacuated first?
Well, this on Tuesday I did that. I evacuated in the angio suite, and then we did an MMA embolization.
You did
burr holes.
How many? 4?
Just
one?
Two burr holes, and I used an endoscope to evacuate the rest.
We used to use Fogarty catheters.
I use a Fogarty. Not a Fogarty. I use a Foley catheter.
But you know the red one.
Yeah.
There was no endoscopes in those days.
Yeah, no, it works very well.
You know, there was a guy, a neurosurgeon, who was chief resident in NYU, Max Kozlo. So we were at Bellevue. There was no CTs yet. Only NYU had CT. And so we had a lot of trauma there. And we had lined down the patients of the angio room. Mm-hmm. This is how I learned how to do bear holes. Mm-hmm. You know, because Max told me, he would do angio. He's a neurosurgeon. I was a radiologist, and we would do bear holes, evacuate. I mean, we had several cases that we saw the middle meningeal pitching, and I embolized it with gel foam, and it stopped.
Sure. Yeah.
Cool. This is 1979. Anyways, okay.
Nothing is new. Right?
But you see this and this. You see how you're seeing the. I think this is more the wall of the sinus that you're seeing. But no, I see no PL. Let's go back to our dural fistula. This is a nice injection. I don't know what's going. How it's helping. Here is still looking for us any pharyngeal. He's got a variation, this guy. Okay. Okay, this is good for. Here's the one that we had from the basal tentorium from the internal carotid artery. You need to put more contrast to get really nice pictures like this.
This is a.
But you see here on the wall. Sorry?
Do you see that 360 turn of occipital?
The turn?
Yeah, there was a turn of occipital that you thought that's where going through the mastoid bone. I was just wondering if you can see it and show it that actually through the bone, since we have both.
Yeah, I'm going to try to see it. Where is my occipital? You did it.
That's the other side.
This is the meningeal.
Yeah, you're right. Yeah.
Auricular.
So that was the. Tom was right. That was the left occipital.
On the left occipital.
Yeah, that was a not. That was.
Yeah,
not
but you're injecting the right side here.
Yeah.
So, okay, let's go to the dural fistula. We're gonna wrap. Let's take this for a moment. Okay. There's a guy called Christopher Conyard, who came up with a classification of dural fistulas. And how do we know, or what's the importance of the venous drainage in dural fistulas?
So, I mean, the ultimate pathology would be venous hypertension, vasogenic edema, and hemorrhage.
Right. So we want to think which ones are dangerous, which ones have a poor natural history, and which ones are benign. And it's all due to the venous drainage. Here you have venous drainage down to the sinus, right? There's no evidence of thrombosis. There is no evidence of reflux to the intracranial drainage, right? So this is called type 1. I hate all this type 1, type 2, 2B, 2, 3A. The bottom line is there's no thrombosis. There's no venous reflux. There is no cortical venous drainage, which is the most dangerous. And within the cortical venous drainage, if you have bumps and lumps, you will see patients with dural fistulas that will bleed here because the venous drainage goes there. And many times when it goes through, the tentorium or something, maybe a restriction, that's where they balloon out. So this one is, I would say, type 1, benign. Here the problem is the noise. Many times patients finding out the cause of their noise may be enough to calm them down. Some people are really affected by it. And the reason I tell is because there are patients that have subjective tinnitus and we can't find the cause, and they think they're crazy. They think they have a person inside their head. I mean, it could be quite disturbing. And then you go to other things like jugular, diverticulum, or like we saw over there, or a big jugular bulb. And then you do maneuvers like turning the head and see what happened to the noise, or compressing the jugular vein. Sometimes very difficult problem. And there are cyanosis of the sinus without dural thing, and that's the ones that Cornell primarily, Dr. Goban came up with stenting, a stenosis, but then you topic about that. That's another topic. Okay? So what are you going to do with this lady?
So choices between transarterial and transvenous.
You're going to treat it? My first, we have to have judgment. Not only you got a hammer, not everything is a nail. This lady is in her 40s, has a dural fistula, no question about it, but has a benign dural fistula. So the question is, number one, should she be treated or not? Then we go as to what type of treatment we can do, right?
Yeah, that's right.
Okay, so what would you do? This is in your hand, or this is in somebody family member of yours.
I mean, it's symptomatic in the sense causes tinnitus, and she's actually in her 20s, and I assume it will affect her through their life, so I would think we can do a conservative treatment in the sense that we try to decrease the blood flow.
What kind of a conservative? How did you call it?
Conservative.
Conservative. What kind of conservative treatment would you recommend?
Taking down one or two branches, which are least
you want to
dangerous.
ever half pregnant?
Pardon?
Half pregnant. You
Hard to
understand what I
do
mean by
that.
half pregnant? And so you're gonna do what? Embolize the middle meningeal artery, embolize the occipital. Okay.
Yeah, the branches which are not probably I won't. Yeah. So.
And how would you embolize? What are the risks?
So the middle meningeal, the risks are affecting cranial nerve 7 and 8. I have to pass through the origin of petrosal.
4, 5, 6, 7. Okay, but not in you're not gonna embolize the eye.
Yeah.
If
So
you're gonna
you
embolize,
branch.
you're gonna come very close, somewhere here or somewhere here, right?
Yeah.
So it's relatively safe.
Yeah.
But what are you gonna use?
So I would. So I have to take down the point of fistula. So I want something that can depend where I position my catheter. If I'm close enough, I can use glue because that's more adhesive.
You could use diluted glue.
Yeah.
But I would say dural fistulas today, DMSO-based agents are far better.
Yeah.
Because you have the ability to inject, stop, inject. You need to cast the whole thing. Otherwise, you're gonna mess it up. If you start on messing with this lady, she gets mad. If you do a proximal embolization, she's gonna become more symptomatic and more difficult to treat. If you partially thrombose it, you may thrombose the sinus and you may convert that to a more dangerous lesion by treatment. So if you're gonna treat it, you're gonna try to get rid of it, I think.
It looks like my experience of using microwires on my cat is very limited, obviously.
Yeah,
But
okay.
it looks like big enough for me to get closer to the fistula point from the.
Okay, so you're gonna go. What catheter would then you okay? You decide to treat it.
Yeah.
I would not treat it. I would observe it. I have a lot of patients for 30 years, 40 years with type 1 dural fistulas. And the group from Toronto has a very good series. They follow hundreds of them for many years, and they seldom become malignant because they seldom become problematic. We follow them. We have a very strict protocol. You know, you tell the patient, explain them it's benign. You know, calm them down. They don't have a dangerous thing. You have a baseline MRI. You can do an MRI on a yearly basis. If you see cortical venous drainage, then you bring it back and reangio and treat it. If the noise goes away, I want to know. You tell the patient, the noise go away, you call me. He says, why? It goes away, I'm fine. Why would the noise go away? And what does it mean? Or could mean?
Well, that shows that because sometimes you would imagine if the flow thrombosis, maybe thrombosis happen.
Yeah, but what if it thromboses and it goes to the other side? Or it thromboses and goes to a cortical vein?
So
Remember the Indian and the cowboy?
Yes.
If it's no longer draining to the bone, the patient may not hear anything.
Yeah.
So the fact that the noise changes, the pitch changes, the noise disappears, is not a sign of, not a good sign. It could actually be a warning sign that's trouble because it rerouted itself. So if the patient knows, doctor, the noise went away. Okay, come, we'll do first an MR, and may actually, even the MR shows nothing different, may do angiogram, because why did the noise change? Okay, very important. And that's how you know the follow-up of this patient is. Okay, if it's got cortical venous drainage, never bled up, like you treat them. If there is thrombosis of the sinus and it's rerouting, but otherwise no other symptom, you may argue to wait, but I wouldn't mind if you treat it at that time. So there's already. Now, we assume that we're going to treat this one. There are two things that we want to do. We want to get rid of the malformation, and we would like to save the sinus. So as we were talking, which would be the best catheter to treat a dural fistula? From all the catheters that we have.
I think it's big enough for a headway.
Headway. I would not use a headway. Yes, you can use a headway. What was the best catheter you've ever seen to inject Davis or Onyx or Phil or whatever? What's the best catheter we have?
I would imagine that
Don't imagine. This is not science fiction. Come on. There is a little balloon in the tip.
Scepter.
Why is the scepter the best?
It gives you flow control.
It gives you everything, man. You don't have to reflux all the way to the petrosa. You have flow control. You start injecting here. It goes in there. You see a drop going into the sinus. You stop. Okay, and then the next one you inject will do this. You can actually get sometimes through only one branch with a scepter the whole thing. Okay, so that's the best catheter to do. But to make it even safer, you said there was a transvenous and transarterial. So transvenous is very easy to cure this. What would you do transvenous? To cure it.
It looked like that.
Fellows, the first thing I guess is that looks like, that doesn't look, it is or it's not.
That there is not a single fistula. Part of it looks like it's on the
That's why I put you this I gave you two images. This one, which shows you that there's got this network here.
Yeah, exactly.
And this one that shows the network here.
Yeah, so superior and inferior part of the sinus both have fistula drainage. So that's why it made me.
With transvenous, you can do something very simple. Just close the sinus and get rid of the fistula. But I want to save the sinus. There's actually a very elegant technique that you can do. You can put a yeah, but we don't have those. But the Balt is going to come up. There is a nice big balloon. You can put a balloon in the sinus, okay, while you inject the liquid embolic through the arterial side. And that saves the sinus. What's the name of the balloon that's made by Balt? They're going to bring it to the United States. I can't remember the name of the balloon, but it's a very nice balloon and very easy to get it there. You don't have the balloon, you want to save the sinus, you could put a stent. You could put a wall stent, and then you do the injection of the liquid embolic through the meninges. It really works very well too.
The other advantage to putting a wall stent in this carotid, if we're thinking about it anyway, is that she has that diverticulum there, which may be the reason for her tinnitus, or at least a contributor.
No, the tinnitus is this dural fistula. Do you remember the vert we saw? This.
You could put some coils in that diverticulum if you wanted to.
On the way. No, you get two procedures. No, I'm kidding, but remember that we had this thing? Where did we see it? In the carotid, no?
There you go.
You know, this thing.
Some people have that and no fistula and they
Correct.
have tinnitus.
Yeah, but I wouldn't treat it just. But if you put a stent here, it will take care of that thing. Okay.
Very interesting. Thanks, Dr.
That's a great. Dural fistulas are fascinating.
So one thing I don't understand. So if you have thrombosis in the sinuses.
No, I don't see any thrombosis.
No, you said it could be a precursor.
And by the way, this is developmental. This is how this patient was born. Right?
So you mentioned that if there is thrombosis in the sinuses, that can lead
the
to...
pathophysiology of the dural fistula is a pathological recanalization of a thrombosed
Okay.
Okay. Now, who was there first, the chicken or the egg? We don't see any evidence of thrombosis here. The MR was a little interesting in that we saw, where is the MR?
But can fistula itself cause thrombosis? Venous sinus thrombosis?
The fistula itself?
Yeah.
No, I think the fistula is the result of. Now, the high flow can produce. Wait, there was another one. This one. saw something that looked like thrombosis. I think this was this thing. I think this is just dilution of the. This is the sigmoid. We're catching it, we're catching it like this, so you're actually seeing two things. This is the same vessel, but you're just catching it. So I think it's dilution of flow more than thrombi in it. To look for thrombi, MR angio is not the best. Is to use the T2, and then you look at it. Okay.
Thank you so much, Dr.
Thank you.
Berenstein. That was great.
Okay.